Okay, so I'd like to welcome everybody to the September 10th, 2025 meeting of the Oregon Healthcare Workforce Committee. And let's see, next slide. I'm Ian Strauss. I use he, him pronouns. I am the chair of the Healthcare Workforce Committee at the moment. And so we'd like to go through. I'm currently a retired federally qualified health center administrator, as well as a consultant in healthcare administration. If folks would, as we call out your names, so next slide. Uh, okay, sorry, little, whoop, yeah, there we are. Okay, as I call out your name, give us your name, your pronouns, and the organization that you're associated with. Uh, Elena,
Good morning. My name's Elena Shablowski. I use she and her pronouns, and I am a dentist and dental director at La Clinica, which is a federally qualified health center in Medford.
all right, welcome. Alicia,
Hi, everyone. I'm Alyssa Sloan. I am the brand new healthcare provider incentives and program coordinator at the Oregon Health Authority. Just started on Monday, so still getting to know everyone. My first meeting today. But yeah, looking forward to it. Thank you.
okay, welcome. Alicia Jackson, Hoi Vu, Eric Weiser,
Eric Weiser, pronouns are he, him. I am a family physician at OHSU, but I also am the Assistant Dean of Rural Undergraduate Medical Education, and I direct the Oregon AHEC.
welcome. Uh, Gabriela Carrillo, Gretchen Horton Dunbar, Jason Johnson, Judy Geiger, Kelly McKnight.
Good morning, Kelly McKnight with Options Counseling and Family Services, she, her pronouns. Thank you for having me this morning.
All right, welcome. Larissa Mejia Medina, Laura Chan, Levi Anderson, Manu Chaudhry, Megan Holland,
Good morning, everyone. Megan Holland. I'm a family doctor on the South Coast. I work for Coquille Valley Hospital, a critical access hospital, and I'm the OHSU Regional Associate Dean for the Campus for Rural Health.
welcome. Molly Reynolds,
Good morning, everyone. I'm Molly Reynolds. I use she, her pronouns. I'm the program manager of the Care Pathways program with RISE Partnership, which is a labor management partnership that supports home care workers in the state of Oregon.
welcome. Rob Ross,
Hi, Rob Ross, he, him. I'm a family physician. I'm a bit rudderless since I retired on July 4th, but actually, St. Charles Healthcare, and I'm associated with the Madras residency program. I'm going to teach there actually starting this afternoon. So,
oh, welcome. Congrats. Bob Lieberman, Dr. Hemmings, Stephanie Grayson,
I'm Stephanie Greisen, she, her pronouns. I'm the Chief Human Resources Officer at Adapt Integrated Healthcare.
All right, welcome. Surya Karlapati.
Hi, good morning. I'm a psychiatrist. I work for the Oregon State Hospital in Salem.
All right, welcome. And Tessa Christensen. Okay.
And
That's
even I saw that Jason Johnson joined us, if he wants to introduce himself.
okay. Jason, welcome.
Yeah, thank you. I came a little late, so apologize for that. My name's Jason Johnson. I use he, him pronouns. I'm a dean of Portland Community College, and I support a bunch of the healthcare programs at the college. It's good to see everybody. Also, just to notice that I have an accreditation site visit going on today, so I'm going to have to hop off the call at 11 to meet with them. So I'll have to leave a little early today.
Okay. Well, thanks for letting us know and welcome. Okay, next slide. Okay. So let's see. For guests and OHA staff, first off, welcome and thank you for, OHA staff, thank you for all the work you're doing. Please put your name and the association you're with in the chat if you would. That would be great. Okay, next slide. Okay, our meeting today, it looks like there's going to be quite a bit going on today. We will be starting with, the general housekeeping and approvals. We'll get an update on the Oregon Health Policy Board and what's been going on with the OHA. And then we'll move pretty quickly into a presentation from the Oregon Center for Nursing and the Oregon Nursing Association on the state of nursing in Oregon. We'll take a very short break and then move into a legislative update to get an idea of what's going on in the legislature. And then when that completes, we'll have a conversation. As some of you may know, as a committee, we are responsible for the healthcare workforce needs assessment that's put out every other year. And we did one in just recently, had one go out. But we're looking at more planning, a better way to create a more complete needs assessment for the next round. So we'll be discussing that, and Neelam and Deepti will go through that with us. And then we'll do a few next steps. So, okay, next slide. It's our meeting today. Okay, so health equity definition and the framework. Next slide, please. So really the framework of everything we do in this committee is based on the health equity definition. And so we've taken up this practice to read the health equity definition at the beginning of each meeting to really center that for everybody, that this is the place where we're coming from in the discussions and decisions that we make. And so I'll read this for now unless somebody else would like to. Okay. So the OHA, OHPB health equity definition. Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. Okay, next slide. So that's where we're coming from. Next slide is our questions for the equity framework. I'm not going to read each one of these today, but especially committee members take a little time to go through these and to really, and think about how this applies to our work with the healthcare workforce. Next slide. Okay, so the next piece is going to be looking at our July and August meeting summaries. Those were sent out, I believe, last week to folks. So first off, does anybody have any updates, comments, changes, anything we missed for the July 2025 meeting summary? Okay. So do we have a proposal for approval of that summary? Anybody willing to?
I'll move to approve.
Move to approve, sorry.
And I'll
okay,
second.
Okay, we have a move in a second. All right, let me go through here and read off names. Give us a yes, no, abstain on this. Elena Shablonsky,
Yes.
Alicia Jackson, Koi Vu, Eric Weiser,
Approve.
Gabriela Carrillo, Gretchen Horton Dunbar, Jason Johnson,
Approve.
Judy Geiger, Kelly McKnight,
Approve.
Larissa Mejia Medina, Laura Chan, Levi.
Approve, but I don't think that I can vote.
Right, that's right. I'm sorry, Laura. Okay, Levi Anderson, Manu Chaudhry, Megan Holland,
I approve.
Molly Reynolds,
I approve.
Rob Ross,
Approve.
Bob Lieberman, Dr. Hemmings, Stephanie Grayson,
Approve.
Surya Karlapati, Surya, I think you're on mute.
Approve.
Oh, thank you. And Tessa Christensen. Okay, and then up to the beginning again for the August meeting summary, August 2025. Any comments, corrections, updates? Okay, can we get a motion to approve?
I'll move to approve it.
Okay, and then second.
A second.
Thank you. All right, here we go. Alina Shablonsky,
Approve.
Alicia Jackson, Koi Vu, Eric Weiser,
Approve.
Gabriela Carrillo, Gretchen Horton Dunbar, Jason Johnson,
Approve.
Judy Geiger, Kelly McKnight,
Approve.
Larissa Mejia Medina, Levi Anderson, Chaudhry, Megan Holland,
I approve.
Molly Reynolds,
Approve.
Rob Ross,
Approve.
Lieberman, Dr. Hemmings, Stephanie Grayson,
Approve.
Surya Karlapapi,
Approve.
and Tessa Christensen. Okay, well, thank you very much. That takes care of our voting for today's meeting. And next slide. Okay, public comment. So Deepti or Neelam, do we have any public comment requests at this point?
I have not heard about any requests for public comment. How about you, Jordan? Have you received any?
No, I did not receive anything for public comment.
Okay, so anybody in the meeting currently who would like to give public comment? Okay, hearing no comment, we'll move on. Next slide. Okay, OHPB and OHA updates. So I will pass that on to, is it Deepti and Neelam today?
Yeah, I'll be doing the Oregon Health Policy updates on behalf of Melina Moran, who couldn't join us this morning. So I'll do my best to summarize what happened at the August meeting and then also the September meeting, which was just held yesterday. And so the August meeting was held in Medford, Oregon. It was one of their traveling meetings where they also do site visits. It started with Director Hathi provided an update on Oregon's response to recent federal changes. She reiterated that there's no changes in Oregon health plan benefits at this time. She also talked about reproductive health and that through a lawsuit that Oregon, along with other states and DC, a judge ordered the federal government to continue reimbursing Planned Parenthood facilities through Medicaid. And so all that is functioning as it used to function, and there's no changes to available services at this time, and that lawsuit is pending. There are more details about this and other federal updates on the federal changes website, which I'll put in the chat in just a minute. At that meeting, the board also heard from some organizations in Southern Oregon, including the Birch Collective, which is a integrated delivery system and model of care for people with mental health, substance use disorders, medical, dental, pharmacy, housing, and care coordination needs. So they kind of do it all. And so the board heard from several members of that collective at their August meeting. The September meeting was actually just held yesterday, and it also included an update about federal changes from OHA's Health Policy and Analytics Director, Claire Pierce-Warble. She talked about vaccine availability in the state. And so OHA has heard that in response to recent federal policy changes and a lack of federal guidance, that some pharmacies are limiting appointments for new COVID vaccines. The national advisors are still finalizing their guidance on who should get it and how. Oregon has joined with 3 other states in an alliance so they can provide clear evidence-based information around vaccines. There's more information available on the federal response website about that. There was also an update at that meeting from the Behavioral Health Division, including from the Behavioral Health Director, about recent projects and sort of where things are in behavioral health. And there was also a presentation from our healthcare provider incentive program about the budget allocation for the next biennium. And we have Jill on the call from OHA who's going to be providing an update about that next. I think that's it for OHPB updates. Does anyone have any questions? Okay, great. Well, oh, go ahead.
Just one thing, Deepti, just a correction. It's the Birch Grove Collective for the record. Yeah.
Okay, thank you. Great. I will move us to OHA updates. And Jill, would you like to talk about the incentive provider program?
Sure, thanks, Deepti. Hi, everyone. Jill Boyd. I use she, her pronouns, and I'm the Healthcare Provider Incentive Coordinator. And as you recall, we presented to you the 25-27 budget allocation for approval at the August special meeting of the Healthcare Workforce Committee. There was some really great discussion, and we eventually did get approval, and we made sure that everybody kind of from the Healthcare Workforce Committee felt comfortable moving forward. We did have the Oregon Health Policy Board meeting yesterday, and we also presented an updated presentation based on your feedback about the Healthcare Provider Incentive Program budget. The outcome of that was the Oregon Health Policy Board did approve the budget. They approved the incentive budget allocation and partial administrative budget. Their request was for our leadership team to work on preparing a cost modeling analysis for the administrative budget. And so they have approved the budget based on last biennium's amount, which was the $2.95 million. And so then we're going to be working with division leadership and our budget team to conduct this analysis and be able to figure out, when the best time is to come back to the Oregon Health Policy Board to request additional approval for the administrative budget piece. But if you recall, that was the main the main topic of conversation at the last Workforce Committee meeting when we presented this to you all, and no surprise to any of us, that was the main point of discussion for the Oregon Health Policy Board as well. So they provided us with some really nice guidance on how we can prepare ourselves a little bit better, and we'll be coming back in the next as soon as we possibly can. It really depends on the collaboration between our division leadership and our budget team. Thank you.
All right, thank you, Jill. Do we have more or anything else on the OHA updates?
Yeah, this is Deepti again. I'm going to be giving just a little pitch for our committee recruitment. And so, as you know, the Healthcare Workforce Committee is recruiting for new members. Recruitment is currently open, and we're accepting applications from now until October 3rd. And so we're really hoping that committee members and staff and guests can help get the word out. We're recruiting for at least 6 voting members and for 1 additional student member. And we're especially looking for candidates that have experience working with CCOs, tribal health, academic and educational organizations, and with Medicare and Medicaid and the Oregon Health Plan. We're also looking for candidates from the traditional health worker, nursing, oral health workforce, and the pediatric maternal health workforce. And then in terms of geography, we also have some gaps in the committee. And so we're looking for candidates that reside in Northeast Oregon, Southern Oregon, and the North Coast. But we're open to, all interested applications. So we would really love to get your help in getting the word out through your network. If you know of people that would be a good fit for the committee, please send them the recruitment notice or have them email me with any questions. I had sent an email last week with the recruitment announcement, and I'll resend that after this meeting. We are hoping to go through the pool of applicants and then set up individual interviews with interested parties the week of October 13th. On that interview panel, we have Ian, who's graciously volunteered his time, and some OHA staff. But if you are interested in participating in these interviews, please let me know. I also wanted to mention that the committee functions best when we have a chair and a vice chair. And right now, as you know, we've been operating with just Ian, with just one chair. So we ask that you please consider running for chair and vice chair for 2026. Besides facilitating these meetings every other month, the chair also helps to set the direction of the committee, and they meet with OHA staff and our board liaison, Melina, once a month for about 45 minutes to an hour. And so those are the main responsibilities, and we hope that there's some interested committee members. We'll be talking about that also at the next committee meeting, which is in November. And you can email me with any questions, or Ian with any questions. And yes, we'll be doing elections for that at the next meeting. One last update, I wanted to mention that we have new support staff for the committee. Jessica, that we previously had on the committee, she left for another OHA position. And now we have Jordan Heath, who's going to be supporting our committee. And Jordan was previously working with the Medicaid Advisory Committee, so she has lots of experience working with public meetings and OHA meetings. That's it in terms of the OHA updates. I also put a link for some written updates as well. Thank you.
All right. Well, thank you, Deepti, and also Jill for your information. Just so everybody knows, you can nominate yourself for chair or vice chair, or other people can nominate you. So either way, we would love to have folks who are interested reach out to Deepti, let us know what's going on. Myself as well. Okay. Just a little bit of housekeeping. I am not going to be able to attend our November 5th meeting. So we're looking for somebody to chair that meeting. So again, if you want to reach out to me or to Deepti and let us know if you're interested. Again, you'd attend a 45-minute leadership meeting, and then to kind of get a feel for what's going on with the meeting, and just to discuss what's happening with the OHA staff, and then work through running the meeting. And really, the OHA staff have been great in supporting certainly myself and the rest of us so you have all the help you could need to do that if you want to take on that role. We'd love to have you. Okay, next slide. Okay, next slide. All right. So our first presentation today is supporting and stabilizing the nursing workforce in Oregon. And I'd like to introduce Janet Bloom, the Executive Director of the Oregon Center for Nursing, and Jesse Kennedy, a nurse practice consultant from the Oregon Nursing Association, who will move forward on this presentation. Thank you both for coming.
Very good. Thank you. And should we just use the presentation that's been submitted here, or do you want me to control it, Jordan? I guess that's the question for you. Because I can always say next slide, please.
That's up to you. I'm happy to just keep doing slides.
Why don't you just keep doing slides? Welcome to the committee. Really great to have you. And I'm going to exit out of the slide that I had up. So first of all, thank you so much for having me here. My name is Jana Bitten. I am the executive director at the Oregon Center for Nursing. And with me today is Jesse Menzik Kennedy. And because we're going to be kind of doing this a little bit together, I was thinking that maybe this would be a good time for Jesse to introduce himself. So, Jesse, why don't you introduce yourself and then we'll come back to the next thing. Oh, can't hear you. Okay, Jesse's going to do some sound checks. While he's doing that, I'm going to let him keep working on that. So I'll just tell you about Jesse really quickly. He can work on that because I need Jesse to speak in a little bit. So you got to fix that in just a little bit. Jesse is with the Oregon Nurses Association, and I'm really glad that we're both here today. I think a lot of people sometimes think that the Oregon Center for the Nursing and the Oregon Nurses Association is one and the same, and we really are two separate organizations. Give it a go, Jesse.
Can you hear me now?
Yes. All right,
Okay. Jesse,
go ahead.
Yeah, so my name is Jesse Menzik Kennedy. I'm a nurse practice consultant for the Oregon Nurses Association. As Jenna said, we have often overlapping interests, but definitely wide range of things that we look at. I also am the board appointed consultant for the Oregon Student Nurses Association, so I work very closely with the Student Nurses Association. Um, Yeah, we overlap on a lot of the stuff that we talk about, and Jenna is always helping us to look at the workforce and where we're going to be going next and what it is that we should be looking at. And then we take a lot of feedback from our members, which is about 15,000 now, and we try to incorporate that with all of our work and with all of the research that's going on.
Yes. The Oregon Nurses Association and the Oregon Center for Nursing, we all partner with the other nursing organizations that are in the state, such as the Oregon State Board of Nursing, nursing educators, the Hospital Association of Oregon. We kind of have this interconnectedness when it comes to the nursing workforce. So I'm really glad that he's here. So thank you so much for having us here. I really was hoping that today we could kind of go over about three different things. And so the first one I want to talk about is a little bit about the nursing workforce in Oregon and how we are collecting the data and what we know, just a very broad overview of what's happening with nursing workforce in the state of Oregon. And then after I talk about that, I'm going to turn it over to Jesse, who's going to talk about what are some of the things, the policy, the health policies, the things that we are doing in Oregon to address the concerns that are coming up about the nursing workforce? And then when we were asked to speak on this, one of the issues that we were asked to address is specifically information about the licensed practical nursing workforce and about accelerated nursing programs. So I have a whole section on that. If you have any questions, you can jump in anytime. You can put them in the chat. We're all pretty good about, managing Zoom at this point. So if you have any questions, please jump in. Jordan, next slide. So I do want to talk a little bit about the Oregon Center for Nursing because I think a lot of people may have been really familiar with the Oregon Nurses Association and the work that they've been doing, but the Oregon Center for Nursing probably less so. So I wanted to just really quickly tell you we are a nonprofit organization. We were founded in 2002. Specifically to look at the nursing workforce in the state of Oregon and try to understand just the data and the data about the nursing workforce and really go as deep as we can to understand where are the gaps and how do we make sure that our nursing workforce is supporting Oregonians and making sure that they can get the health care that they need. We do this in a very collaborative way. I mean, the Oregon Center for Nursing can't do everything, and the Oregon Nurses Association can't do everything, and the Oregon State Board of Nursing can't do everything. But as we work together, we all build on our skills so we can support the nursing workforce in the best way that we can. Go ahead, next slide. So one of the things that we do at the Center for Nursing is we really try to understand the nursing workforce, and we want to know how to describe the nursing workforce. Typically, this is how we do it. We go through and try to determine what is the demand for nurses in the state? How many nurses does Oregon need? And then we match that with how many nurses do we have? How many nurses are currently working in Oregon? Who's licensed in Oregon? And then we balance those numbers out, but we also are looking at the education component because there are a lot of nursing schools in Oregon, and there's a lot of Oregonians who want to be able to get really good jobs and develop themselves professionally. And we want them to be nurses in Oregon as best as they possibly can. So we want to know, what do we know about our nursing schools in Oregon? Who's graduating? How many of them are going into the workforce? What does that whole picture look like? So that's what I'm going to talk about today. So go to the next slide. So what we do is we looked at the Oregon Employment Department, who put together some occupational projections for 2023 through 2034 or 2033. That might be a typo. This is an important thing to keep in mind because one thing that we talk about when we talk about nursing, the Oregon Center for Nursing is looking at the entire ecosystem of nurses. We're looking at registered nurses, we're looking at CNAs, we're looking at LPNs, advanced practice nurses, which include nurse practitioners, and also doctorally prepared nurses. We look at all of them. 68% of the entire nursing workforce is made up of registered nurses. So the data that I'm going to be showing you today is the registered nurses. Just this right here. We're just going to be talking about registered nurses because a lot of times when we're talking about policy and we're talking about workforce, it's the registered nurses that come in just because of the sheer size of it. So this right here, these numbers are really describing to you what's going on with the registered nurses that are specifically working at the bedside. If you look down in the note, these are the nurses that are assessing patient health. They are administering nursing care to ill or injured people. You know, they can advise patients on health maintenance. It does not include Jesse, the nurses that are working at the Oregon Nurses Association, well, in that role, it does not include the nurses that are working as managers or leaders in a hospital, and it also doesn't include nurse educators. So just be aware of that. So for the Oregon Nursing Department, they looked at the employment for 2023, and it was about 45,000 people that were employed in nursing in the state of Oregon. They anticipate that by 2033, they're going to need probably about 5,000 more people, around 4,000, 5,000 more people, at 49,000 people. Now, what's interesting about that is that the industry growth is 4,637. So what that means is that the number of clinics that are going to be opening, hospitals that are going to be opening, the growth that we expect to see over the next 10 years, we expect to see about 4,600 some people that we will need to be nurses. The more important thing is the next part where we talk about replacement openings. And in replacement openings, those are the people who are leaving the nursing workforce. And that we need to replace them to be able to take care of the people that are here right now. So why are they leaving? They're leaving because they're retiring, they're moving out of state, they're just noping out of nursing altogether. They're not working in nursing anymore. So that means if you add the industry growth and the replacement openings together, that means that we're going to need our total openings over a 10-year period of time is going to be 28,801. And if you divide that by 10 for a 10-year period of time, that's 2,880 that we're going to need every single year for 10 years in order to be able to meet what the employment department is saying our need is. So remember
Jana,
that number, 2,880 per year. That's what we're going to need. Go to the
can I
next.
ask? Can I
Yeah,
ask?
go jump in. Jump in.
Does this just include institutionally employed nurses or hospital employed nurses, or does it include like surgical centers and outpatient departments and all of that?
It includes nurses in that setting if they are doing these jobs. So this is not specific to hospitals, if that's what you're saying. It's for a multitude of settings. Yeah. Okay. Next slide. So let's take a look at how many nurses we have. Over the past 12 years, the number of nurses that have been licensed and practicing in the state of Oregon has been steadily growing. We do break out how many nurses are licensed versus how many are practicing, because just because you have a license to practice in the state of Oregon doesn't mean you're here, doesn't mean you live here, doesn't mean you work here. It actually doesn't even mean that you've got patients here. You may not have a patient load, but you may have a license. This is a formula that was created by, I believe, the Oregon, the Health Policy Department many years ago. They call it an activity rate. We call it a practicing just so we can kind of understand it a little bit. But this is based on their data file. And you can see from this chart, we've really grown from 2010. We started with our licensing just a little bit above 440,000 people, and we've moved up to about 70,000 people. In fact, we have more people practicing now than we had licensed in 2015, 2016. So the number of nurses that are coming into our state is really exploding. And of course, in 2020, obviously, the number of nurses in Oregon really exploded. Next slide. This is what's going on with nursing education. So and for those of you who may not be familiar with this, in nursing, you can graduate with an associate degree in nursing, or you can graduate with a bachelor degree in nursing. You take the exact same licensing test, and you are considered a registered nurse. So we count both programs for registered nursing. The darker green line are the associate degree programs that are delivered at a community college. The lighter green line are the bachelor degree programs that are delivered at a university. And you can see that it was kind of remaining steady for a really long time, except for 2024. The data that just came in showed that we are really exploded with the number of people that are graduating from our nursing programs, but they're graduating in the bachelor degree programs. The associate degree programs, if you notice that green line, is staying about the same. However, if we just look at this, the average over the course of the years ranges between 1,300 to 1,600. That's kind of the range that we're looking at of the number of people that we're graduating. So remember the other number we talked about, 2,880 per year, and we're graduating 1,300 per year. If you do the back of the napkin math, you can see that we're not graduating enough people to meet what the employment department has determined what the need is. Next slide. What this doesn't take into consideration are the people that are moving into the state. So what we have here is there's two different ways that you can get licensed in the state. You can go to nursing school in the state of Oregon, and you can take the test, the NCLEX, the licensure test in the state of Oregon, and get your license. And that is called license by examination, which is the purple line that stayed pretty steady but kind of grown over the course of this slide. Or you can go to nursing school in another state, you can take the NCLEX, the test in another state, and then you can move into Oregon, and then we'll give you a license via endorsement. That's gone nuts. We've had so many people come in from out of state and become nurses within the state of Oregon. For a time, it was almost right now, our growth rate, our population growth rate for the number of people moving into the state of Oregon is less than 1%. And yet our growth rate for the number of nurses that are moving into Oregon to practice, that's around 4%. So we have more people that are the people that are moving into Oregon, a large proportion of them are nurses. They're moving here to practice nursing or to treat Oregonians in some way. In 2020, I'm looking over here because I know my research director is actually here right now, and I need him to correct me if I'm wrong. I believe it was in 2023 or 2024, the Oregon State Board of Nursing in 1 year alone processed about 9,000 licenses just in 1 year. We know that the number of people that are coming in from out of state, we know that there is a really large portion of them. They don't have an address in the state of Oregon, and they don't have a work address in the state of Oregon, which leads, and we've surveyed this group twice and asked them, what do we know about you? And we know that a lot of them are working as travelers, they're working as travel agents, or coming into the state doing a short-term assignment and then leaving. We know many of them are case managers in other states. We know many of them are doing telemedicine in some other areas, but there's a big portion of them that are getting an Oregon license because their employer is requiring it. And that's because there is a hospital system like Providence, for example, who has practices in multiple states, and they want to be able to have some flexibility to move their staff around if they need to. So a lot of times they will require their nurses to get an Oregon license, even if they live in Alaska and have absolutely no intention of ever treating Oregon patients there. However, about 45% of the nurses that are coming in to the state, they are living here, they are practicing here. And so if you take the number of people who graduate from our nursing programs, the 13 to 1600, and you add that with the 45% of the people that are coming in by endorsement, we way overshoot that 2,880 number I told you to remember. We way overshoot it. And yet, employers are still saying constantly that we do not have enough nurses, that there is a nursing shortage completely across the state, and they are not able to hire enough nurses. So, what gives? And that's one of the things that we've been working on. Next slide. We have a leaky bucket, is what's going on. We are really, really good. Oregon is great. We pay our nurses really well. There's good representation. We take care of them really, really well. There's incentives for nurses to go from their state and move to Oregon and practice in Oregon because this is a very nurse-friendly state. But when we get here, they're leaving. And that is something that is a problem. It makes no sense to try to get more people, to try to recruit more people to come here from another state, to try to overwhelmingly increase our nursing programs if they're just going to go into a workplace, stay for a little while, and leave. There's data that's showing that nurses in the first year of their job will leave 30% of the time. They will leave their job in the first year. So if all of that is happening, we got to plug these holes if we actually want to have a stable nursing workforce in the state of Oregon. And we are doing some things to do that. And that's where Jesse's going to come in. So Jesse, hop in here and tell us, what are some of the things that we're doing right now to plug these holes?
Yeah, that's a good question. I would still say we're definitely still have quite a bit of loss that's happening. I mean, we're still looking at a 16% turnover rate annually. Um, we're still looking at the average healthcare facility turning over 103% of their nursing healthcare staff in general every 5 years. I think the biggest push that we're doing right now is in the rural areas. We have some research done in La Grande that's covering a lot of the rural counties about trying to get nurses acclimated to their communities. So it's a $5 million grant from HRSA that OHSU La Grande Dean Patty Barfield is working on, which helps to acclimate them to the community. There's 80 hours of additional work within the community, and the goal is to help them to feel more a part of the community, to help them find ways that they can tie into the community, because in general, as Jenna mentioned, they tend to leave. And so we're trying to figure out a way to do that, to get them to stay. There is a lot of research just starting about how to keep them, how to improve retention. A lot of it is in the work environment in general, so making sure that they have a voice within the workplace. I think we've seen over the last couple years that there's been a lot of discontent with between nurses and their facilities about their voice within the healthcare system. We've moved away from a lot of the shared governance that was so strong about 5, 6, 7 years ago, to a place where a lot of the nurses are just in general not feeling a lot of ownership of the practice. There's a lot of discontent. The House Bill 2697, which just passed, just went into effect in June. The goal was to create a baseline of nurse to patient ratios, which hopefully would help to get to a place where workload is manageable. Because when you look at exit surveys for those facilities that do exit surveys, it's always the staffing, the workload, moral injury, and burnout that are the number one rationale for people leaving employment within a facility. And so the goal with 2697 was to start figuring out a way to, I don't know, a way to stabilize that, a way to at least set a floor for what that looks like. But if you go to the OHA website, I'm sure you'll notice that we've had almost 2,700 complaints about noncompliance since June 1st. And at June 1st, they basically just reset the counter because there was so many that were not able to be investigated in that time. And so instead of the model that OHA was using before, where they surveyed everybody every 3 years and then investigated complaints, now it's just a complaint-driven model. And so OHA is looking at trying to figure out how to enforce 2697, how to figure out ways that the nurses and the administrators. And so the way that our staffing law works, hopefully folks are familiar with it, but it's kind of a 50-50 setup with the staffing committees within each facility. Half of it is hospital administrators that are nurses, then half is direct care nurses. And they work together with the unit-based practice councils to come up with a staffing plan for each unit, which is supposed to be based on the acuity of the patient, the experience of the nurses, um, and the overall workload of everything that's going on. And so there's any number of ways that they can determine what those numbers should be up and down. The goal is to try to rely on national standards and evidence-based practice to be able to find out what the best mix is. But as we've seen, there's a lot of facilities that are still not able to reach that balance of things that the administrators can agree with and the direct care nurses as well. And so I think we're still in a point of trying to reach equilibrium again, where they're able to come up with a plan that makes sense for everybody. But I think until we get to that point, I think we're still going to have a leaky bucket. I think we're still looking at ways to improve um, the environment within the facilities to get to that place where we stop getting that huge turnover rate. We also have research that's going on at OHSU that hopefully is going to start improving the retention for community areas. And so there's a research going on at OHSU for nurses to be able to bill directly both CMS and private insurance, which the goal is to be able to help those who are in the care coordination space, care managers, RNCWs, to be able to um, work more directly with the insurance, work more directly with patients, and not have that additional layer of cost. Because as I'm sure many of you know, with HR1 happening, there's going to be a big there's going to be a big decrease in Medicaid funds going, especially to the rural communities. And so trying to find a way that those nurses are able to stay doing their job, that the patients are able to get the care coordination that they need, that they're able to get their DME, that they're able to get all of the appointments that they need and ensure that they're continuing on their healthcare trajectory rather than dropping back down and coming back into the emergency room as a more acute patient, which is what we tend to see right now. So I think right now we're um, striving for that equilibrium. I think there's a bit of a shock from 2697 happening. And so folks are still trying to figure out how to balance that. But as I said, we're up to almost 2,700 complaints right now since June 1st, according to their website. And I think they've started investigation on about 1,500 of those. And so we still have a lot to work through and a lot of catch up to play as far as getting the environment to a place where nurses are going to be able to stay, are going
I
to choose to
think,
stay.
yeah, thanks, Jesse. One of the things I do want to point out, because I'm not sure that this committee or people know in general, is that Oregon as a state, we're kind of we're kind of brave, and we go into some of these spaces when it comes to nursing workforce that other states haven't gone into, and they are absolutely keeping an eye on us to see what's going on. The 2697, we're the only California implemented something similar to this, gosh, 20 years ago, something like that. We're the only other state that has implemented these kind of standards at the level that we've implemented them, which is really kind of incredible. There's a lot of states that are looking at this, that at how this is being implemented here because they're trying to replicate it. The other thing is what Jesse was talking about is the bill about having registered nurses be able to bill Medicaid in certain circumstances. And the study that's happening at OHSU, we passed a bill in Oregon that would allow that. There's a committee that's going to be, that is, are they meeting right now? I'm not really sure if they're meeting right now. They're
Yeah, the
meeting
rack has just
to,
started.
yeah, they're meeting right now to put the rules together. We have people from all over the country that are looking at that because they want to know how can their registered nurses bill for services without having it be over a physician in those circumstances where there isn't a physician, such as federally qualified health centers or rural places or that kind of thing. So we kind of are on the forefront when it comes to nursing workforce and some of these issues. What I'm describing here, this leaky bucket thing, this is not unique to Oregon at all. We are just we're just very brave in the solutions that we're willing that we're pushing forward, and it's kind of exciting the work that we're doing. Before we move on into licensed practical nurses and accelerated nursing programs, does anybody have any questions about all of that? Eric does. Go ahead, Eric.
Yeah, I just have a question, and I love the leaky bucket, both analogy and picture. So, like that, kudos for your clip art choice.
Yeah.
It's awesome. But I think about the leaking bucket, my question is it as leaky for those who graduate in Oregon as for those who are coming out of state? Like, is the leaky bucket the same intensity for both of those groups?
My understanding, that's a really good question. Our OCN's research director, Rick Allgeier, is here, and he was answering some questions earlier in the chat. And if Rick, if you know that answer, jump in here because I'm not sure if we've broken it out between the people that are coming in from out of state and the people that are graduating here to see if that intensity of leaving is different in those groups. We know from the discussions that we've had with people that it kind of doesn't matter. The problems that they are being that nurses are being pushed up against are are kind of it's a systemic, these are systemic problems. It's not something that people in Oregon are, if we're educating them in Oregon, that they're somehow less prepared for the systemic problems that they're experiencing than people from another state. It's kind of their systemic problems, they're kind of hitting everybody around the same way. So I don't know that we've broken out those two groups as far as research is concerned, but the anecdotal studies that we've been doing, yeah, or the stories that we've been collecting from nurses is showing that it kind of doesn't matter because the obstacles that they're facing are systemic.
I think, well, what I would just push back a little bit on that and say
Sure.
the solutions may be different depending on those groups. And my next question that I lead to, and this is kind of like the two-parter, is, the nurses who are coming in from out of state, are they coming equally to both rural and urban areas?
They are primarily, I'm going to have Rick jump in here. Rick, do you know this? Because this is the study that Rick did a study on this particular group of people in 2022, and I don't want to misquote it. My understanding is that they are going into rural areas,
Yeah.
mostly. Rick, go ahead.
Yeah. Hi, everybody. Rick Allgaier. I'm the research director at OCN. We did a study on this just before the pandemic because we had noticed that the number of nurses endorsing into Oregon just skyrocketed in the early 2000s. So what we did is we surveyed them. Anybody who had an endorsed license, we asked, and a lot of them were moving into rural parts of the state. Much more so than proportionally more than folks that are being graduated from Oregon nursing schools.
Yep.
But is that my question too, is like, can you tease out travelers out of that? Because, when you look at that
Yeah,
rap,
yeah. We
look
do
at that,
tease out. We almost every time we ask nurses about anything, we ask them if they're serving in a traveler role.
Mhm.
okay.
And while during the pandemic, a lot of nurses were, nowadays it's not so much. The last survey we looked at was about 6% of the workforce was serving in traveler roles. So most of these folks are not. They're not serving in traveler roles, and a lot of them are going into the rural hospitals and into community-based settings in rural communities.
Do you know if the travelers are equally proportioned between urban and rural?
No, we haven't looked at we looked during the pandemic, and what we really saw during the pandemic was that travel nurses were starting to practice in settings that never used travel nurses before, primarily in long-term care.
Yeah.
Other than that, I really don't know.
It's yeah. It's good. It's a valid question, Eric.
Yeah.
Thank you.
Mhm.
All right. Other questions about this? All right. We'll talk about, because I heard this committee was interested in licensed practical nurses. Go ahead to the next slide, Jordan. Since I understand that you are interested in licensed practical nursing and accelerated nursing programs, let's move into that section and I'm going to share some information about that. And then if you have other questions, then we can discuss that. So go ahead, Jordan, to the next slide. So kind of like the same projections that I showed you before about registered nurses, here are the projections that we have for LPN employment from the same data source of the Oregon Employment Department, where we can see in 2023, we had 4,315. Our projected employment was not nearly as much. It goes up by about 400 to 4,757. They anticipate industry growth being at about 442, with replacement openings about 3,562. That means the total openings over a 10-year period of time is about 4,004 over that 10-year period of time. What's so interesting about LPNs, especially in the state of Oregon, is that when I have talked to physicians or CEOs of hospitals or other places and they talk about hiring LPNs, a lot of times they'll say, I would gladly hire an LPN if I could find one because they're very, very hard to find. And in Oregon, we have some LPN programs. I think some LPN programs after the pandemic did expand to accept some more students, but still the job growth is not really there. And with the replacement openings, they don't usually retire from LPN. That's not a retirement position. They're usually going on to become a registered nurse or doing something else in the healthcare profession. Next slide. So I wanted to kind of talk a little bit about nursing education because I think that this is especially important when we're talking about accelerated programs and where they work. If you look over onto the left side, this is kind of the ladder that has been set up for nursing education. You can get a certificate, get a certificate as a CNA, so a certified nursing assistant. Takes about 105 hours to do, maybe 4 weeks, could be a little longer. A licensed practical nurse will take you about a year, and the jobs that you can do are over on the side there. With the associate's degree, usually it's about a year's worth of prerequisites and then you get into the program. So it's basically 3 years of education and then you can become a registered nurse. With a bachelor's degree, it's a 4 year, you become a BSN registered nurse, and that also opens up the opportunity for nurse managers or nurse leaders, some other things that you can do as a BSN. With a master's degree, that's the graduate education, then you can become a nurse midwife and a nurse practitioner. I recently learned that in 2025, nurse anesthetist is now required a doctoral degree. So that is a misprint that I just discovered yesterday, that actually goes into the doctoral degree, and then with the doctoral degree, you could get a PhD or a DNP. It is not required to start at the top and move all the way down. That is not a requirement. It's an expensive way to become a registered nurse and to get into the practice. It's not a requirement. You can jump in at any of these places. But if you do jump in at any of these places, then sometimes there are other programs, which is what's over here on the right side, that just kind of explains how to bridge between those, how to move between those if you jump in at different places. So for example, if you get an LPN, there are LPN to RN bridge programs that take about 18 months that you can do, and then you'll end up with an associate's degree in nursing. There are RN to BSN programs, which are for those people who get an associate degree in nursing, and then they move on with that program in about 12 to 18 months. Then they can then get a BSN level of nursing. In Oregon, we have an applied baccalaureate degree that can be conferred by our community college that are called Bachelor of Science nursing programs. So that is where if a community college that is credentialed gets a Bachelor of Science nursing program at their school, then someone could go to the associate's degree, finish that, and then be conferred a degree from that nursing program from that community college. We do have that in Oregon. We also have the accelerated Bachelor of Science in nursing. So those are for people who don't have any nursing experience at all. They have a bachelor's degree in a different field, philosophy, literature, biology, math, whatever, but they do have earned a bachelor's degree in something else. They could do an accelerated Bachelor of Science in Nursing. It'll take 12 to 18 months. And then at the end of it, then they will have a BSN. And then finally, we have something called a direct entry DNP. And so this is for people that are, maybe you're in a bachelor degree program and you're about to finish. You could do direct entry where you skip over that master's degree and you can get you can get the doctoral degree of the DNP, not the PhD, but the DNP. There's a new program that the Umpqua Community College has started where you can start in a nursing program at Umpqua Community College, get your associate degree, and work through this so that at the end of it, in a partnership with OHSU, they'll have a direct entry. They'll have a DNP at the end of their conversation or at the end of their education. I think a lot of people don't understand, or they don't know all the intricacies of the nursing education. So I put together this not very pretty, a little bit ugly chart to try to explain it. And I hope that this was helpful. Does anybody have any questions on how this works? Did anybody know about this ahead of time? Did you all know this? Yeah, Elena is like, I knew a little bit about this. Robert knew. Okay.
This is Jason at PCC.
Yeah.
This is super helpful. So, as somebody who oversees a ton of healthcare programs, of which nursing is not one, this helps me a lot. So a couple things that I just maybe thoughts I'm having in my head. Number one is from a student lens, this is incredibly confusing.
Yeah.
So, I think that's something for someone to think about around how the transparency to students can maybe be improved about this. I'm also most curious about the scope of practice differences between LPN, RN, and BSN master's degree. Like as the education rises, what is the scope of practice difference here? Is there a slide or any documents that can help clarify that?
I don't have a slide on that today. Jesse, is that something you could speak to off the top of your head?
Sure. I mean, the biggest difference between LPN is that they cannot do a full body assessment. They can't do the full assessment and care plan management. So that's really the biggest difference. Everything else within the scope of practice can generally be um, learned, practiced, and then demonstrated to be able to get to that scope as far as most of the care for patients. But within long-term care facilities, for example, that's why there's a requirement for there to be RNs there no matter what, because the RNs are the only ones who are able to update the plan of care and to do the full of body assessment within every 24 hours. So that's really the biggest one. I would also add that one of the barriers that we're looking at as far as being able to expand the education of our nurses is that clinical faculty, nursing faculty for the most part, the entry level is at the master's degree. So we're looking at quite a bit of investment to be able to get to that point where they're able to educate nurses. And then also, if you look at the reimbursement rate for somebody who has a bachelor's degree or even an associate's degree working at the hospital is quite a bit more than faculty gets paid to be able to educate those nurses who are then going to be making more than them at the hospital by the time they graduate. So I think that's one of the areas that we've been trying to find a way to understand a little bit better as far as that scope for the master's degree and the bachelor's degree.
Thank you. I've got so many questions, but I'll ask one more and then I promise I'll stop.
Never
The
stop
other
asking questions.
well, the other thing I've heard is that different hospitals or different organizations and clinics have different requirements. So I've heard like OHSU doesn't hire associate degree nurses. They only hire bachelor's degree nurses, whereas other hospitals and clinics will make use of associate's degrees. And I'm curious is what the rationale that Oregon has for what degree level is appropriate to be a nurse in a healthcare system.
Yeah, I'll take that. And Jesse, if you have anything that you want to add to it, there is no Oregon rationale. It is
Okay.
completely up to the employer. The degree that is conferred at the associate degree level and the bachelor's degree level is a registered nurse. And for either one of those, that is and a setting can hire a registered nurse, whether they have an associate's degree, whether they have a bachelor's degree, it's the same qualification. There has been a very, very large push over the last decade for people to try to get more bachelor prepared nurses. And so kind of culturally, hospitals will choose to have bachelor's degrees. Also, there is an accrediting body called the Joint Commission that requires, I think it's 80% of their staff needs to be at a bachelor educated level for them to be able um, to practice. There is some literature that suggests that BSN level nurses are safer in hospitals when it comes to readmissions and such. So that's why at a hospital setting, they'll generally defer to hiring a bachelor's as opposed to an associate's degree in nursing, but it's the same degree. So long-term care, for example, will hire associate degree traditionally, but there isn't a set standard. It's really kind of up to the employers. And Jesse, do you have anything to add to that?
Only that I think the maldistribution that we were talking about a little bit earlier is probably the rationale for OHSU for the most part, because there are a lot of bachelor's programs in the area of OHSU. So, I mean, there's a saturation of bachelor's prepared nurses in Portland, whereas the rest of the state doesn't have those. And yeah, there was a very big push for BSN in 10 up until the pandemic, where the goal was to make sure that everybody who gets an associate's degree continues on to get their BSN within 10 years of initial licensure. That's fallen a bit by the wayside with the pandemic, and I think everybody's still trying to get back to a place where they have enough nurses. I mean, obviously, it didn't necessarily bring about a whole lot of new issues with the nursing workforce, but I think it brought a lot of those issues to the front.
Yes, absolutely. Thanks.
Fascinating. Thank you for this presentation. It's really helpful.
Yeah, thanks, Jason. In the chat, Neelam asked the question that they have heard anecdotally it can be harder to find employment with the accelerated nursing degrees compared to more traditional degrees. Can we speak more about that? This is basically what I can say is that when an accelerated Bachelor of Nursing, you're going to get a bachelor degree at the end of it. And the majority of our accelerated Bachelor of Science nursing programs are in the Portland metro area, which, just as Jesse said, is saturated with BSNs right now. So it really isn't that they're getting an accelerated degree and that people are going to choose an accelerated bachelor degree over a traditional one. It's that the majority of the accelerated programs are in the Portland area that's already saturated. So that might be adding to the challenges that those students are experiencing or those graduates are experiencing. Molly Reynolds, go ahead.
Hi, yes, thank you so much for this really interesting. I just wanted to point out that especially when we look at sort of like the equity framework and like making education accessible to folks and kind of reducing those barriers, it is a little bit of an issue or a little concerning sometimes that these programs are set up that so that folks have to take long stretches of time away from employment.
Yes.
Something that my organization is working on is creating CNA programs and LPN programs that are sort of modified and schedules so that people can continue working and earning money while they're advancing in their education and career. And I think that's something that we lose sight of sometimes is that these are systems that are set up for folks who have that sort of dare I say, privilege to be able to take time away from working full time to advance in their education and careers.
You are kind of hitting the nose on the head there. Whatever, I'm saying the wrong thing, but what I'm trying to say is there are no part-time nursing programs in the state of Oregon. I don't think there's part-time nursing programs anywhere anymore. This is not something you can go to night school and become a nurse. That's something from the 80s and 90s. That doesn't exist anymore. If you're going to be going to be a nurse, and I have some experience with somebody that was working for me that was going to nursing school and watching what her schedule just devolved into as she was trying to go to school and trying to work full time. It was impossible. It was impossible for her to do. Nursing school, not just in Oregon, this is not an Oregon thing, it's across the United States. Nursing school requires you to take time out of your life and your day and your schedule and everything and to just focus on nursing in order to get through. And that does set up some systemic barriers.
Yes, and just to point out again that like the organization that I work for is a labor management partnership, so SEIU 503. And we are working on developing pilot programs for these kinds of modified programs, like a modified LPN program. We actually just sent a cohort through, or that are currently going through the program, and providing sort of these modified hybridization curriculums, half online, half person, with wraparound supports and those kinds of supports for folks so that we can reduce those barriers to entry into the field for a diverse set of Oregonians.
Yeah. Thank you. I saw that Dr. Hemmings had her hand up, but then she put it down. Dr. Hemmings, did you have something you wanted to say?
Yes. Are you able to hear me?
I am, yeah.
So I'm okay. So if Joint Commission requires a certain a higher percentage of BSN versus associate level registered nurses. I'm trying to understand. I think I heard both of you say that there is no difference. Are you implying that there's no difference in skill set between an associate RN versus a bachelor's RN?
The difference mostly is the length of education and also the length of clinical experience as part of that education. The literature that is out so as far as licensure is concerned, and as far as like the skills test that we've put together that to define competency, it's the same test between.
Yeah, they take the same boards. Yeah, I get that.
They take the same boards, whether it's associate degree or bachelor's degree. There's been quite a bit of literature that's showing that patient outcomes and the safety of patients under the care of BSN are generally better. So I think that using that data and that research and that evidence is why places like the Joint Commission requires more BSN so that the hospital or whatever organization is Joint Commission accredited will have that standard and have the promise of those better outcomes.
Okay. All right. Thank you.
You're welcome.
And I can add to that. So I started with an associate's degree and then I did a RN BSN bridge program. And I would say, to speak to Molly's point, is that the more programs that we can move online or to that hybrid setting, the more accessible they are to people with families, the more accessible they are to people who don't have all of the advantages that some of us do. I was able to work as an associate degree nurse while getting my bachelor's degree. I'm now working on my PhD, and initially that was all in person as well. They are finally shifting it to be more online to make it more accessible. And I can say that has been incredibly helpful in being able to get more people into the cohort, to be able to get more people access to the education, because it definitely is a burden if the only way that you can get that education is to go there physically. And I would say when we were talking about the distribution of nurses in those rural areas, based on the research that I'm doing right now, it seems like the places that have a closer proximity to nursing schools, community colleges, tend to have much better access to nurses versus those who are 2 or 3 hours away from a nursing school, where you would be expecting those nursing students to be able to do clinicals far away, to be able to travel all that time to be able to do their clinicals, and then to be able to apply there. So I think the more we can open the accessibility of the education, the better we'll be at getting nurses to those places that are traditionally underserved.
So I think we're at time. And if we are, let's just really quickly, Jordan, if you could just hit the next slide and I can show you. This is a little bit more information about the supply, the work setting, and the education of licensed practical nurses. I wasn't sure if that's what we wanted to talk about, but I've got that here for your reference. And go ahead to we have until 11? Well, then let's go back here. Let me tell you about the licensed practical nurses. You can see that we have about 6,150 that are licensed, 5,000 some that are practicing, 83% that work full time. Still, they're pretty small. But as far as education goes in the state of Oregon, we have 6 LPN programs and 4 LPN bridge programs. 85% of them will offer a certificate. There are some programs, not all of them, but there are some programs where if you're in the middle of an associate's degree, you can get your LPN license while you're going to school to get your associate's degree or your BSN. So we've got 6% of people that are practicing as an LPN. They actually do have their ADN or they have a BSN, and 6% have diplomas. We don't have any diploma programs in the state of Oregon anymore. So either those people are coming in from out of state that do still have diploma programs, or they're older LPNs and they got a diploma long ago and they've been working as an LPN ever since. And you can see with the work settings where they're working: skilled nursing facilities, clinics or offices, home health, hospice, hospitals, and residential care. Mostly they're working in skilled nursing facilities, clinics, or offices. Dr. Hemmings, go ahead.
Okay, so one of my concerns here is that I think it's great that we're trying to increase the nurse and professional workforce, and we're looking at, CNAs, LPNs. However, one of my concerns is that as you go, the lower you go in terms of most professions, the color changes, right? So you'll find that the demographics is very different in terms of race, ethnicity, language, cultural differences for CNAs, LPNs as you go up an associate, blah, 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 right? And I guess one of my concerns is that when we're thinking about expanding and creating more opportunities, that we don't pigeonhole or selectively, create a situation where we have more people who are people of color who are being pushed into, whether, intentionally or not, into the CNA LPN role, right? This is kind of reminds me of, when I was in high school or whatever, and certain kids got pushed into AP classes, right? And were on the track to go to college, whereas others weren't. So I just want to be mindful of that as we think about, expanding in terms of how we communicate this and how we structure any kind of, programs that we're not unintentionally or intentionally, gearing more people of color, different socioeconomic status into these lower tier type professions. That's a concern that I have. Whereas, then you see as you go up, it gets a lot more wider, and socioeconomic status class is very different.
Yep.
Yeah.
Yeah, thank you. That's a really good point. And thank you for bringing that up and making sure that we have that at top of mind. There's a note in the chat that says, I don't believe that any accrediting body, including the Joint Commission, require a certain percentage of BSN. Magnet certification does require a certain percentage of BSNs. And I apologize. I think I'm using the magnet certification and the Joint Commission interchangeably. You're right. It is the magnet.
Yeah, and OHSU is magnet. So that's why they have that. Yeah.
Exactly. So yes, I apologize for that confusion. Okay, next slide. Got 2 minutes. We're going to get through it all. When we're talking about accelerated programs, again, the majority of these are in the Portland area, but this gives you a sense of how many graduates we have in the Portland area that are from our accelerated programs. So Concordia has the most. It's a private university. There used to be a Concordia locally, but now it's part of St. Paul, Minnesota. Our OHSU Portland graduates about 101, and that's in the Portland area. Linfield College is also in the Portland area. They graduate about 37. Bushnell is a little bit further south. It's kind of closer to the Salem area. and then OHSU Ashland, that's Southern Oregon. So you can see when we go back to talking about how it's difficult for accelerated BSN programs to find jobs in the Portland area, it's because the majority of them are in the Portland area. A lot of them are competing with each other, especially when they're coming from places like Concordia. And if you go to the next slide, I wanted to share this with you. This is a map. This is on our website. If you're interested in the nursing education programs that are located in Oregon, the QR code should take you there if you wanted to take a look at it. It's on our website, but this gives you an idea of where our nursing schools, where the nursing programs are located throughout the state. There's a new one that is just coming up here in John Day. It's a for-profit school from Utah that is probably going to be starting a program here in collaboration with John Day Hospital. I don't know if it's up and running yet, but I believe that that's going to be starting soon. But it kind of gives you an idea. We're very concentrated with nursing schools here in the Portland area and along the I-5 corridor. And then our rural places, they got to drive pretty far if they're going to have any classes in person. All right. And I believe that that is everything. Does anyone have any final questions? Go ahead, Jordan, to the next slide. I did not put Jesse's contact information. That was a really bad call on my part. Jesse, can you put your contact information in the chat? Yeah, I apologize for that. I meant to do that. It looks like Dr. Hemmings put the time requirement full-time is by design. It's systemic as it maintains the current demographics of who gets to be in higher positions, socioeconomic status. It is by design. The part of the reason why the full-time position is by design, that these programs are full-time, has to do with the competency tests that we give all of our nursing students in order to be able to pass. There's a lot of information that we're requiring these students to know in a very short period of time. So I think that in the majority of educators that I've spoken to, when they talk about the ability to have a part-time program or the ability to offer more hybrid programs, it causes them a lot of angst at the idea of how are we going to be able to make sure that those students will get all of the information and knowledge they need within an appropriate period of time, that they can take the test and pass it on the first try or the second try. Because in Oregon, we also do have that standard for our nursing schools that their students need to pass their boards on the first or the second try, and we don't give them a lot of chances to do that. So there's a lot of pressure there too.
Okay. So Jenna, Jesse, thank you very much for coming out and speaking with us. This has been very informative. I know I was one of the people with the LPN and accelerated program questions, and you really hit all the points.
Good.
Wondering, so thank you. I appreciate that.
And I'll speak for Jesse here. We'll come back and share all the information that we have anytime that you'd like. If there's anything that this committee is interested in related to nursing workforce, both of us would be really happy to come. Well, I would be really happy, and I'm going to speak for Jesse and say he's also happy to come back and speak to you.
Okay, well, thank you. Thank you. All right, so committee members, it's currently about 2 minutes after 11. And we've got still a lot going on in today's meeting. We're going to take a 5-minute break just to give us a chance to stand up and walk around. So we'll be back here at about, why don't we say, given where we are now, 11:08. And if you would turn your camera back on when you get back, just so that we know that you're here, that would be great. All right, thanks everyone. So now we are moving ahead to the 2025 legislative update, and we have Phil Schmidt, the Director of Government Relations for the OHA. Phil, welcome.
Thanks so much. Appreciate you all having us here. Yeah, thank you for having us here. As your chair said, I'm Philip Schmidt. I use he and him pronouns, and I'm the OHA Government Relations Director. I'm joined by a few teammates who will be jumping in at various points in these slides. And we're going to sort of give our standard legislative session wrap up, but kind of go quickly through things that don't have a really strong workforce angle, and try to slow down and talk a little more about the ones that do. So we could go to the next slide. And I'll let my teammates introduce themselves as they pop on screen and talk. So we'll go through quickly the legislative session by the numbers, the OHA budget highlights. We'll do a zip through of the various bills that we were involved with and what happened with them, and then hopefully save a little time for questions. We can move to the next slide. So as you can see, it was very active legislative session, 3,400 bills. OHA tracks bills that touch healthcare or the health of people in Oregon. So, a little under half of the bills that were introduced, our agency thought touched healthcare or the health of Oregonians. We had some bills that we requested, 10 of which passed. We'll get into which those were. The rest of it sort of inside baseball. We'll move to the next slide. So OHA has a big budget, one of the larger budgets in state government. Actually, not one of it is the largest budget in the state government, 41.9 billion in total funds, which was an increase from the previous biennium. Most of that increase, and indeed most of our budget, is Medicaid and delivering Medicaid services to folks in Oregon. We'll talk in a little while about the Medicaid funding renewal. That was a bill that they passed that ensured that the state side of Medicaid funding was covered for the next few years. There was a pretty large investment in behavioral health, including CCBHC expansion, diversion, harm reduction, and some investments in school and community-based use of prevention. The Healthier Oregon program was continued with funding, and the legislature set aside some funding to protect reproductive healthcare access. And we had some cuts and some programs that weren't funded, and you can see those on your screen. You can go to the next slide. So I'm standing in for a colleague, and then I'm going to pass it to one. So I'll quickly just run through HB 2005, which revolved around civil commitment and aid and assist. This is really relating to folks that are suffering from real mental health struggles and severe mental illness. There's something of a logjam at the state hospital, and a lot of this discussion in this policy was about how our state can move forward in ensuring people who need to be at the state hospital to aid and assist in their own criminal defense can make their way there in a timely way and potentially make it back to the county where they need to be. We have lawsuits and court orders, and it's quite an area of discussion, both in the legislature and then of course in counties and at OHA. So this was a big bill with a lot of implications, carefully negotiated, and probably the beginning of a conversation rather than a final point. And so from there, I think I will turn it over to Robert on our team to walk through several other behavioral health focused bills.
Good morning, everyone. My name is Robert Lee. I serve as one of the senior policy advisors with the government relations team. I use pronouns he, him, his. And behavioral health is my primary portfolio, as well as tribal affairs, veterans, and some of the Medicaid. Happy to be here with you all. One of the Major topics this session was the civil commitment aid and assist, and kind of carrying on that discussion from House Bill 2005, spurred off a number of other bills. House Bill 2059, the behavioral health residential capacity funding bill, that one invested about $65 million to establish a residential behavioral health capacity program, basically trying to establish more capacity and residential treatment facilities throughout the state. It estimated about 200 new beds, roughly preserving about 120 current beds as well. Again, that particular bill doesn't specifically mention civil commitment or aid and assist, but it was absolutely a cornerstone to that legislation. Next slide. So other major behavioral health bills, House Bill 2015, that's the residential behavioral health studies. That's OHA looking at and studying secure residential treatment, secure residential treatment homes and facilities, especially with focus on transition age youth residential treatment homes as well. And then House Bill 2024, this was the major behavioral health workforce initiative bill. It established a grant program, about $4.8 million total, to recruit and retain behavioral health care providers. It also has tribal carve-outs, so recipients of OHA tribal mental health program grants, urban Indian health programs would qualify. Qualified medical providers that offer office-based medication and assisted treatment services, and non-hospital certified behavioral health providers, licensed opioid treatment programs, as well as withdrawal management services. This includes such things as scholarships, loan forgiveness, repayments, tuition assistance, and stipends. And there were also some components to this legislation with investments in the United We Heal Medicaid payment program, which provides various workforce recruitment retention strategies, primarily apprenticeships and on-the-job training. That was about a $860,000 investment. And then there were some additional expansions in workplace protections. Next slide. So other major behavioral health bills, 2013, the expansion of mental health insurance coverage. This particular one included outpatient alcohol and drug treatment programs who have providers that are licensed, and making those essentially eligible for mental health insurance coverage. And then Senate Bill 729, which is the mental health services for IDD, prohibits denying mental health services to individuals based on intellectual or developmental disabilities. And OSU had a very interesting bill, Senate Bill 920, which created a rural community behavioral health promotion project specific to rural extension-based services or rural services for behavioral health, where they will be identifying and convening meetings with community leaders, providers, and other community members to look at the systems for behavioral health in their communities and identify gaps. And next slide.
Thanks, Robert. Hi, everyone. I'm Drogi. I use she and they pronouns. I am also a member of the government relations team, and I work with our equity and inclusion division and our public health division. It's so great to be with y'all today. I will briefly share about Senate Bill 850, which would have expanded regional health equity coalitions to cover more communities in the state. This bill, unfortunately, did not move through this session. We ended up supporting a bill that was led by Regional Health Equity Coalition, Senate Bill 528, which ultimately did not move through Ways and Means in a really tricky budget year. We can go to the next slide. Then moving to Senate Bill 692, which does impact the workforce. This is the Community-Based Perinatal Services Access Fund and Program. It establishes a Community-Based Perinatal Services Access Program and Fund that aims to support culturally specific community-based services during pregnancy and through 1 year postpartum. Another piece of this bill is that it's creating greater access to and establishing criteria for birth and postpartum doulas, as well as certified lactation counselors and certified lactation educators to hopefully increase the workforce for perinatal services. And I will pass it to Phil to talk about health policy and analytics.
Hi, just a few to buzz through here, covering for a colleague who's at a policy conference. We passed a bill that would improve our children's health report and align it with data that we collect and sort of ensure that we were reflecting, so the most recent understanding of what the best data to focus on is, and that sort of thing. So that was great. We have been in a conversation for the past couple of years about the use of the prioritized list of services, and so we had a bill, HB 2917. And the prioritized list of health services is what determines the coverage for the Oregon Health Plan. And we did not pass this bill, but we have a task force, in fact, that's convening now to discuss what could come after the prioritized list phase out. And then we had a couple placeholders that we didn't end up needing. Go to the next slide. I think quickly, we were involved in conversations around, this word is, I get it wrong probably, but hemoglobinopathies, along with sickle cell disease. There were several sort of efforts to really increase awareness, services, identification, and treatment for individuals who have sickle cell or other blood diseases, rather than saying that word again. And this HB 2940 did pass, and will create a process where folks who have blood disorders can be flagged for that staff. There was an effort to really try to get pharmacy benefit managers into a different regulatory structure. It did not end up passing, but it's, we have indications that this is a conversation that will be ongoing. Go to the next slide. John, would you like to take this one?
Sure.
Okay.
Hi, folks. John English, he, him. Portfolio includes Medicaid, education, and external relations. As Phil mentioned at the top of the presentation, this is the hospital and insurer assessment bill. I won't read through all of the bullet points, but the headline here is that this generates about 30% of our state Medicaid funding. So it is a pretty important bill that passed. One thing to note is that with the passage of HR 1, the federal reconciliation bill, there are going to be some incremental decreases to the amounts that certain states can assess or tax. And so that's just something to watch. That's going to be one of the belt tightening exercises that we'll be engaged with over the coming years. We can go to the next slide. I'll just breeze through a couple of these very quickly. 2205 established kind of a level setting for CCO contract length. So setting them all at a minimum of 5 years, but eliminated the need to go in and do a legislative enactment anytime we needed to extend. And so that will hopefully create a little bit more of an efficiency there. 2208, also a bill focused on efficiency, looking at the various reports that CCOs have to pull together and produce, and trying to figure out how we can streamline and decrease the administrative burden to make that work happen more efficiently. And next slide, hospital discharge. This bill does a number of big things. One of the kind of four big pieces creates a dashboard to track eligibility for long-term services and supports, studies regulatory framework for care settings, how to increase adult foster homes and expand respite care. And then importantly, it extends post-hospital extended care benefit under Medicaid up to 100 days. And so the problem that was is being addressed with this bill is folks who are in hospital settings. They are ready for post-acute step-down care and yet have nowhere to go. So this is very much entwined, obviously, with homelessness and trying to figure out how to create safe medical step-down locations for those folks. 549 is about decreasing the amount of time that one has to wait for prior authorization in order to get complex rehab technology approved. For example, folks who use power wheelchairs to access the community, we are trying to make sure that they are not experiencing undue delay by waiting for weeks on end to get power chairs repaired. And so this bill creates a 72-hour turnaround for that. And then 690 is also important in the sense of being related to our 1115 health-related social needs housing waiver. In these instances, folks who have children 12 months or younger and have been approved for the housing assistance benefit and are in an eviction process have the ability to ask the court to extend, push back, if you will, the hearings. And so the whole idea behind this bill is to buy a little bit more time for folks who have been approved but are still waiting to receive the actual check to help take care of their rent. We can go to the next slide. Finally, really quick, this one falls more on the Oregon Department of Education, but it is important in the sense that it does seek to create a centralized, standardized electronic health record database, which is really important because we are doing a lot of work to augment our ability as a state for our 197 school districts to leverage Medicaid dollars and actually bill Medicaid for Medicaid services that are provided in school settings. One of the barriers to doing that well and efficiently is lack of a standardized way to share data across platforms. And so this bill hopefully will help to improve that area. I believe those are all of mine. I'll pass it off to whoever's taking this one.
Oh, I can do it. Thank you. We had a couple of bills that dealt with the state hospital. We were proposing some language in a bill, HB 3051, around restoration and folks that are coming to the state hospital under aid and assist situations. That was replaced by HB 2005, which I discussed earlier. And we did pass some technical fixes for the Oregon State Hospital. So we can go to the next slide. Oh, and then some bills that we, so the Alcohol and Drug Policy Committee had a bill to update their membership and their duties, and that is a independent committee, independent of the health authority. So this was their bill. We had some ideas around modernizing the DUI system. The conversation will continue, but that bill did not pass. We can go to the next slide. And I'll pass it to Megan, I think.
Yep. Thanks, Phil. Hi, everyone. I'm Megan Sanders. I use she, her pronouns. My work in the government relations team is primarily on community and partner engagement and also some support for the public health division. I'm going to talk a little bit about these and pass it over to Em, but I also want to say I know we've talked about a lot of bills and we don't have a lot of time, but if you do have any questions for us, feel free to put those in the chat and we will try to get to them. Just briefly, I want to talk about Senate Bill 837, which is related to Oregon's Volunteer Registry of Emergency Volunteers, known as SERVOR. It did a few things, but notably changed the law so that volunteers can respond to local emergencies without a statewide declaration. So think like in extreme heat or extreme cold conditions. If a local public health authority is looking for support at cooling shelters or warming shelters, volunteers can help with that. It also allows administrative volunteers to be members of SERVOR, which helps to enable clinical professionals to primarily focus on those clinical duties and just allows more folks to be members of the SERVOR registry. And I will pass it over to Em to talk about these next two.
Thank you, Megan. I will briefly share Senate Bill 842 modernizes the hospital oversight licensing fee. So it increases the hospital licensing fee so that Oregon Health Authority can ensure hospitals continue to provide high quality, safe care to patients. And then we also passed Senate Bill 844, which was a number of technical fixes for our public health division. We can go to the next slide. And we can actually, Megan, did you want to briefly share about either of these?
Yeah, just House Bill 2528, neither this one or nor the next one passed, unfortunately, but 2528 would have essentially ensured that synthetic nicotine products, think like Zyn, are regulated in the same way that other e-cigarettes and tobacco products are currently regulated. This conversation will certainly continue in the next few sessions, but did not pass this session. And House Bill 2937 was a bill to modernize our newborn blood spot screening program. It did not pass, but partially because Representative Nelson brought a nearly identical bill that modernizes the program and also provides for long-term follow-up so that our program can connect with families whose children have been identified as having any one of the conditions and make sure that they're connected to community organizations that can provide them resources. And you can go to the next slide. Thank you. Back to you, Em.
Thank you. So moving into House Bill 2380, this creates a provisional certificate for cosmetology if no school offers a program of study in the field of practice within 50 miles of an individual's residential address. We believe that this will make it easier for individuals to gain experience in cosmetology, which could lead to full certification, to generally promote job opportunities, and this will particularly impact individuals in rural communities where cosmetology schools are not readily available. I won't speak to these two other bills, but I do want to highlight Senate Bill 476, which I heard is of interest to this group. That creates a provisional license pathway for internationally educated physicians in Oregon. And under the new law, internationally educated physicians can practice under the supervision of an Oregon licensed physician with a provisional license. The Oregon Medical Board is currently putting together a work group to develop rules for implementing Senate Bill 476. And I'm going to post that website in the chat if anyone would like to get connected to the work that's happening with that. And we can go to the next slide and I'll pass it back to Robert.
Hello again, Robert Lee. So tribal affairs, we had a number of bills. These two, Senate Bill 841 and 835, were brought forward at the request and in collaboration with the tribes. Senate Bill 841, that one had to do with sharing health data with tribes and the tribal epidemiology centers. That one did pass, so we are currently working on that. The purpose of that one is for sharing data and investigating reportable diseases and outbreaks, as well as sharing information on the prescription drug monitoring programs with the tribes. And then Senate Bill 835, that one did not pass. That one has to do with the collection and protection of tribal affiliation data. And that one would have basically allowed OHA to start collecting information and sharing that for the tribes, not only securing it, so it's data security and also sharing, but it would have actually allowed us to track tribal affiliation. So adding T for tribal affiliation to the real DT data that's currently being collected. And with that, we'll move to the next slide and hand off to Phil.
I think this slide should have said questions because we are happy to stick around, answer any questions you had. We threw a lot of information at you. Obviously, we are available at any time for questions through OHA to us or to us directly. Our portfolios and information and our contact information was posted in chat towards the beginning of the presentation by Megan. So please feel free to look us up there and reach out if you have questions. But I'll pause there, see if there are questions. And if not, we'll just appreciate your time here. Oh, it says, can you speak to what the next short session will look like? Yeah, I mean, Short sessions are 35 days in the opposite year from the long sessions. They are historically meant to be about sort of budget reconciliation and kind of updating things that couldn't wait for the next long session. Over the past few bienniums, there's been some major policy discussions during the short sessions, and I assume there may be one or two of those. Because of the limited time, legislators are kept to just a couple bills per legislator. So the number of topics and sort of the broad sweep is reduced. And so given the budget forecast that we have, we saw late this fall, a week or so ago, the anticipation is that revenue is going to fall for Oregon state government. So I anticipate that the short session will be about, sort of the conversation around how to manage falling revenues in our state, and if there are ways to seek efficiencies out of state government to deal with that. So that's what I think this short session will focus on, in addition to maybe one or two sort of policy discussions. But I think it's going to be mostly about the budget. Hope that helps. And that will be in February of 2026. Other questions? Seeing one, where did the bill approving foreign medical graduates practicing with supervision arise? I'm going to turn to the team and see if anyone has sort of specific knowledge. If not, we may have to get back to you about that question.
Yeah, I think you're referring to Senate Bill 476. So that was a collaboration of the Oregon Medical Board really worked closely with the bill sponsor to craft the language that was in that bill. And I shared a link to their website where you can connect with Elizabeth, and she's the best person to chat with to learn more from the Oregon Medical Board about how all of that is moving forward with implementation.
It'll be interesting to see what the qualifications are. Because I practiced in places where that was allowed, and it was not a particularly productive thing to do. But anyway.
That could be useful information to provide in the work group if you were interested in connecting with folks who are creating rules. I think some of that criteria will be decided through the rulemaking process too. It's a good flag though.
Okay. Well, if you send me the link, that'd be good.
All right.
DP just put some more in the chat. Sorry.
Thanks.
Okay. Any committee members, any further questions for the government relations team? All right. Well, thank you very much for a great presentation. This is a lot of really good information. Next slide. Okay. And now we're going to have Neelam and Deepti to work with us to look at planning for the 2027 healthcare workforce needs assessment. Again, this is one of our required deliverables one of our, I think, 2 required deliverables as a committee.
Great, thanks, Ian. I'm gonna get us started. Next slide, please. So just to make sure everyone has the same information, just as a reminder, I know you've all been through the healthcare workforce needs assessment approval, but this is, as Ian mentioned, a requirement via House Bill 3261, which was passed in 2017. The Oregon Health Policy Board is required to approve this healthcare workforce needs assessment and submit a report via OHA to the Oregon legislature every 2 years. The report must consider the workforce needed to address health disparities among medically underserved populations in Oregon, the workforce needs that result from continued expansion of health insurance coverage in Oregon, and the need for healthcare providers in rural communities. And as you all are very aware, this report is initially approved by this committee, and then this committee's recommendation goes to OHPB for its review and approval. The 2027 needs assessment is going to be the 6th report that OHA is going to produce in collaboration with you. And it's due to the legislature by February 1st of 2027, following the Oregon Health Policy Board approval. So we normally will bring this to you in fall for your approval, and then we will go to the Oregon Health Policy Board at their January 2027 meeting for their approval, so we can meet this timeline. Next slide, please. So, it might seem like we're talking about this well in advance. Part of the reason we are is that 2027 is not that far away given the approval process that I just mentioned. And so, we are planning to search for a contractor to work with the committee as well as OHA staff. And we would like to start the process of developing the 2027 needs assessment early next year. And we would also like to have more committee involvement. One example that I can think of was the development of the strategy papers in which the committee developed subcommittees and were much more involved. And so we would like to really have more of your input from the beginning. And we also would like to secure a single evaluator, ideally, for both the needs assessment and the evaluation of the healthcare provider incentive programs. So that, that linkage, the intention behind the needs assessment is partially to inform the investment of the healthcare provider incentives. And so that way, that linkage can be a little bit stronger. And 4 years ago, in 2021, we did have the approval presentations of both reports by the committee in December, and then the OHPB approval next month in January. So we would like to align the timeline and the approvals of both these reports this in the next year and a half, so we can meet those legislatively required approval timelines. Next slide, please.
Okay, this is Deepti Shinde. I'm staff for the Healthcare Workforce Committee. The next 2 slides are about ways to increase committee involvement in the next report, and then also work through a series of questions where we hope to get your feedback. And actually, the bulk of this presentation we've saved for hopefully a robust discussion and getting your feedback about ways to improve the next needs assessment. So some of the ideas that we've come up with so far for increasing committee involvement in the report are to engage the committee in developing the outline of the report and the report content. I think in the past, this has been done mostly by OHA staff and the contractor. And then the first time that the committee is really engaged is when there's a draft of the report. And at that point, it's much harder to bring in any information that you're not seeing or areas of focus that you're not seeing. So we want to start that involvement much earlier. Some of you were a part of a work group that was formed for the Healthcare Workforce Committee around gender affirming care, and the provider work group. And we really thought that that was a more successful model because the committee members were engaged much earlier in the process in terms of developing the report and serving on subcommittees about areas that they were specifically interested in. So we're hoping to adopt a similar process here for the needs assessment. And so we're hoping to also create a few subcommittees that work regularly with support from the contractor that would guide the report's development and to develop that feedback loop. And so, a few examples of subcommittees might be one around primary care, another one around oral health. But that would be, we would work with you to develop what makes sense for those subcommittees and who would be serving on them regularly. We also want to, go back one more, thank you. We also want to involve the committee members in the presentation of the report to the Oregon Health Policy Board, which is a strategy that we used with the gender affirming care provider work group that I had mentioned earlier. I put a link to the 2025 report in the chat. I know for some committee members who are newer, it was the first time that they were involved with that report. I'm also new staff, and so it was my first involvement with that report as well. So just to familiarize yourself with that report, there it is. And kind of the general outline of it is that it had, just to refresh your memory, the contractor in the report, we went through 10 different workforces in differing levels of depth covered in that assessment. And so the 10 workforces that are covered are there. Then there's also recommendations around some key areas that are found in the assessment. There's recommendations for each workforce, and then there's recommendations for each of the key areas. And that's kind of the loose structure of the report. And so next slide, please, Jordan. Great. And so we wanted to save the rest of our time to hear your feedback. I'll just read these questions, but we don't have to go through them in any particular order. But what process do you think that the committee should use to develop the 2027 report? What should be the scope of the report? Are covering 10 workforces, maybe too many? Are there areas of focus that we should zone in on, sort of limit and narrow the scope of the report? Is it trying to do too much, or too little? What are some areas that past needs assessment have done well that you've liked? What are some areas that could be improved on for the next report? What are some topic areas that you would like to see expanded on or eliminated? For example, we think that the Oregon Health Policy Board might be adopting a topic area or a priority area of primary care for their committee. And so if they adopt that area, maybe it makes sense for our committee then to also expand the section on primary care. So that would be one example of that. Or are there areas that should be eliminated or the focus more narrowed? And the last question, what would you like to learn from the needs assessment? I think the needs assessment serves many different purposes, but we'd really like it to be the kind of report that has meaning, and we don't want it to be the kind of report that sits on a shelf. And so we would love your involvement with how to make it more actionable, more relevant, and more usable. So what would you like to learn from the needs assessment, and how should it guide the committee's work? sort of the last question. And Ian, did you have anything to add before we open it up to the committee?
Okay, well, so you mentioned the piece about the Oregon Health Policy Board focusing on primary care. And in that case, we're talking about primary care from the perspective of medical care, oral health, and behavioral health. So those areas being covered, there's quite a bit of ground there. I think one of the things I've found in the past is that it's going to be really important who the consultant is we're working with and their breadth of understanding of the different areas. Because in the past, we've had a group that was primarily medical care centric and didn't have much experience with, especially behavioral health. Committee members, I would let have you all think about the fact that many areas outside of traditional medical care may not be the focus of groups that are doing this work, and making sure that we put our energy into filling out the difference, or at least making sure that we're looking at these, the full spectrum of primary care for the report. So, oral health folks, participation guarantee, at least leads to the possibility of better, more complete depth. Behavioral health, the same. Not that I don't think that medical care is also important in this, but I'll say that the non-medical folks, if you're interested in participating, this will be a good place to get some traction. I think that's pretty much what I've got, folks. Let's see. Deepti, do you want to take this one back?
Yeah, I was going to say, so we have some time to get to hear and get your feedback on these questions, or just your general thoughts about the needs assessment. And we would ideally love to hear from all committee members that are still able to join us if possible. That would be great, and we might even call on people.
Would it make sense to do small groups where people are talking to each other and then coming back and report out in breakout sessions? Or if that doesn't work, I have a couple of thoughts.
Yeah, I love the small group idea. I don't know if, Jordan, how to set that up without notice. I certainly don't on Zoom, so that would be the limitation there. But
I'm sorry, you were talking about wanting to do breakout rooms. Is that what I heard?
yeah, that could certainly be a possibility. We have about 40 minutes to discuss this, and I know that Ian has to leave at noon, and it sounds like Tessa does as well. So, Neelam, what do you think is the best way to solicit feedback? I'm counting how many members we have.
Yeah, I think there's only like 6, and then it would go down to 4 at noon, actual committee members on the call. So I think let's leave it. I think we are a small group already.
Okay.
I think let's just leave it here.
Well, what I'd like to say is that recently I got a message from Representative Nose asking for ideas for the February short session that don't cost money. And part of what would be helpful in the committee's work is suggestions for improving the workforce and making sure we have folks that we need here filling those positions without a budget note, because it's just the reality of the place we're in right now. And it might be reducing administrative burden or some other things. So that's one piece of feedback I would offer. And the other is, this is a 2027 report at right about the time that some of the initial Medicaid cuts are likely to be, and changes are likely to be implemented. So just that framework needs to be considered.
Yeah, I think that's a great point, Kelly. I think like understanding the fiscal impact of decisions that we make, and sort of what is realistic in our current environment can be super helpful. I'll also chime in. So I got to serve on the gender affirming care subcommittee, and what was really helpful about that was a more kind of DP, you had said this too, a more narrow scope. So we were answering a very specific question. And I think like literally being given a Google Doc link, feeling like, oh, we have input into the words and the sentences and like um the structure of this report. Whereas when we get the needs assessment, often my experience in the 5 years I've been doing this is like, this is a fully fledged report and we want your rubber stamp on it. Um, and so I think your identification of like the point of entry is super important. And I think the two types of work were very different. And I think my big question is like, what is decided already? Where is their legal structure? It has to look this way. We have to have this information. It has to like be in this way. Like there are things that we don't actually have influence over, which is fine. That's like, the inherent nature of being on an OHA committee. And I've never been super clear like what we actually have influence over in the report. So I think like a color coding, like slides or content in green is like very changeable, or we could add detail or take detail away or ask different questions or manipulate the data. Information in red or black or orange or whatever, like this legally needs to be in the report. There is precedent for this. We cannot change this. So I think that would be one question that I think it would be helpful to identify, what do we have influence over and what do we not? And then I think sharing like wins and success stories, that has been something that that like closed loop feedback process I think can be missing in the scope of our work. And so I think it would be cool, super cool to start with like, in 2021, the workforce committee reviewed this and had this discussion and made this suggestion. And this is 4 years down the road, this is the impact that it's had. Sort of queuing up the conversation with, here's the real impact that you can have and like where the committee has actually had influence in the past. I think that might prime our brains a little bit better. Those are my thoughts.
Not to be the negative Nelly, but also what kind of recommendations were made that didn't work, so that we don't want to attempt to replicate or that might need to be tweaked in order to be more successful.
I love that we're talking about this so early, and I would just like to put in a plug that it would be really helpful if we could have some scheduling of work group meetings that's more in advance. When I tried to serve on one last year, I found it very challenging because the meetings kept getting put, with a week notice in the middle of an afternoon of my clinic schedule that I couldn't just bump those patients out of. So if we know we're going to have work group meetings about something, if we can start planning those way far enough in advance that I can have blocks in my schedule. And I don't want to make it all about me, of course, but I'm sure all of us have conflicting meetings and it can be hard to commit if we don't have those scheduling blocks way in advance as much as we can.
The other thing I was going to say, I've always considered primary care to contain or be relational to behavioral health intimately because so many conditions are affected by behavioral health stuff. I also like to think of behavioral health incorporating a lot more than just primary care and our needs, because it's a huge range. You've got the severely mentally ill that need psychiatric services, and you've got, um, you know, uh, people who need temporary counseling or things that are available hopefully in primary care with association with behavioral health. So you can weave, I think, a report that includes all those things in primary care, if that's what they're really interested in.
And I know we only have a handful of committee members still on, but I was wondering, are there any specific areas that you would want the needs assessment to answer, the questions that you want answered that you feel would help the committee's work?
I know this has been a topic that we've discussed previously, but the healthcare workforce pathways and what's available in the different areas of the state, and then also some discussion about people that are trying to transition from other careers into healthcare workforce. What kind of programs do we have available for assistance?
Yeah, I'd second that. And also I think the nursing conversation today really elucidated sort of the flow. I think it would be interesting, like the leaky bucket clip art, kind of where our graduates, especially in those first 5 years of after training, at least in the dental world, we see a lot of transients in that time. So I'd be curious, like who is applying to training programs, who's getting into training programs, and then after they graduate, how many stay in Oregon at like 1, 2, 3, 4, and 5 years, I think would be interesting as well.
Yeah, I was also thinking about the nursing presentation earlier today, and I especially liked how they broke it down. One of their slides had a very simple diagram about kind of three components, like demand, how many nurses does Oregon need, supply, how many are currently working here, and then the education, like who's graduating from the nursing schools. And just to have that like clearly broken out for the workforces that are included in the report, I think would be really helpful.
Yeah, I'm just going to jump in and agree with you all. I think that the career pathways is particularly interesting, and again, how to address those kind of like barriers and disparities in who is entering the workforce and how far they're able to advance within the workforce. Because I think if we can create pathways where pathways that facilitate people's advancement in certain ways, then we can begin to kind of address some of these gaps and diversify the workforce in general in Oregon.
And also, what's the attrition rate of folks that begin a program and complete the program? And likewise, folks that get their degree and enter into the workforce in the role that they trained for and then stayed there. Or as you pointed out, Molly, advanced in that same field.
The other point that was brought up this morning during that was a really important one, is that you cannot depend on licensing or boards to accurately reflect who's practicing in Oregon, and it's the same across all professions. So trying to figure out a way to get the right accurate data is very important, because a lot of the data sources they're not really data, they're just garbage, and they don't reflect the reality of what is actually going on the ground for patient access.
And we're taking notes on what we've heard, and we can come back to the committee. certainly around like what we're actually required to do around the House bill. I'm forgetting the number that established this needs assessment and what we have flexibility on. I think it's been some time since I reviewed that as well. So we'll definitely get back on that.
Yeah. Can you go back, Jordan, a few slides? Because that language is taken straight from the House bill. Just one more slide back, Yeah. This is what the House bill says. And then in addition, it also says that it should be used to inform the investment of provider incentives.
So really then we have a huge amount of flexibility in how we do the needs assessment, it sounds like, and what areas need to be covered versus what should be covered. And I think like looking back at the different needs assessments over the years, because I know that's not something everyone has time to do or should do, but they've really grown also in length. I think some of them have been, 30 pages, and others, the most recent one was well over 100 pages. And so sometimes longer is not always better. And so I think also figuring out like the core of what we really want it to do and tell that story really, really well, even if it means a shorter, leaner, narrower scope for a report.
Yeah, Deepti, I'm wondering, thank you so much all for your great feedback. This is, great initial thoughts. If we could send those back to you and do a survey, so that way we could come back to the November meeting with those results, and have further discussion. I wonder about doing that, especially given that, we don't have that many members of the committee, but, we really appreciate all your wonderful thoughts for those of you who are still here.
That sounds great, Neelam. It sounds like a great way to organize the feedback and then also hear from the majority of the committee that's not on this call. So
Yeah.
Sounds great.
And I want to put in a plug for psychiatry access because even though I'm a family doctor in primary care and worked in rural Oregon for many years, the access to psychiatric services that I learned through trying to start a psychiatry program in Bend is far worse than primary care in many respects. And we have no plan to address that. I mean, it's been reflected in so many things in Oregon, like the closure and federal mandates to fix our state hospital. The fact that everyone from rural Oregon has to travel to Portland or Eugene to get alternative psychiatric treatments, that all my behavioral health friends, LCSWs, PsyDs, family doctors, everyone else has incredible problems getting consultations for the complex multi-diagnosis behavioral health patient. And so, it all weaves into primary care in some ways because without that access, many patients are lost to proper treatment facilities and or resources. So just that's a bias of mine. I know that many other medical specialties are going to be in very short supply as well. And I mean, our current, the big, beautiful bill is not going to help us in any way, shape, or manner that I can see.
I think that brings up a great point about Deep to you about you were saying the increasing length of the report, and then Bob,
Yeah.
kind of I mean, maybe this feels icky to say, but maybe there would be value in saying like this year we're focusing on these two areas. Or I know when we made the position papers a couple years ago on like diversity and retention and health and wellness and resiliency, the the advice that we got was like pick two recommendations. Don't give 15 recommendations, pick two. And it's harder to say, it just the impact of that very focused message can be greater. And so that might be worth a preemptive discussion ahead of the needs
Yeah.
assessment to say, this is going to be our focus area, or these are going to be our two focus areas. We'll include a snapshot of what the full workforce assessment looks like. And like this year, oral health is like not our priority, and that's okay. We're going to name that. We're going to be okay with
Well,
that. And and so this year psychiatric is, or behavioral health is, or nursing is, or whatever. I think that could
well,
be valuable and help rein in the report a bit.
well, and also I'm not trying to be completely confined to medical things, because in the dental area, to get into a periodontist in Central Oregon takes like 10 months.
Yeah,
And
there's
so
one.
there's
There's one
one.
east
So
of
it's
the,
like,
yeah.
it's like, this is not, this is not confined to medical things. It's other things as well. Periodontal disease is medical as well, of course, but it's like there's shortages in all sorts of access.
Yeah, I agree completely. And obviously, yeah.
But I think focusing
Yeah,
on one or two things would be really good,
yeah.
because I
Naming
think
it's
that
all important. Yeah. Yeah.
legislatures don't read 100 pages. They're lucky if they read one. So maybe we should go for one.
Yeah. The neat thing too, as you mentioned, we know periodontal disease has an impact on Alzheimer's and heart disease and diabetes and all,
Yes, I
and so
know.
like a rising tide lifts all ships. And so if we say we're going to focus on behavioral health this year, we actually know that that will also have a positive impact on medical outcomes and dental outcomes. And,
Right.
it's going to improve patient, I have a belief that it will
Oh,
improve patient outcomes across the board. Yeah. So anyway, I think it would be neat, Deepti, to do some sort of like survey or discussion like far ahead of the report to identify one or two priority areas that we focus on.
That is great feedback. Is there any other feedback that any of the committee members have at this time before we wrap up? We can definitely talk more about this at the November meeting, and send out a survey and discuss the results at that meeting to get wider feedback. I know Ian had to drop off the call at noon, and so we still have about 18 minutes left, but I think we can just end early if there's no additional feedback. I wanted to mention there's a educational webinar that's coming up on October 8th at 9 a.m. We think that the topic is going to be around maternal health, but we're still working on that. And then I also wanted to mention the next meeting, last meeting of the year, we think, unless there's a special meeting needed, but that will be on November 5th, Wednesday, November 5th, at the same time, 9:30 to 12:30. Neelam, is there anything else you'd like to add before we wrap up?
No, I don't think so. I think that's great. Thank you, everyone. And we're happy to give you some time back in your busy schedules.
thanks. Bye.
Great. Thank you. Bye. Have a good rest of your day.
You too.
Bye-bye.
Thanks, Neelam. I just wanted to make sure everyone got off.
Yeah, no, thank you so much, Jordan. Appreciate it.
Sure. Have a great rest of your
Great
day.
support this. You're awesome. Thank you so much.
I'm glad. I'll talk to you soon.
Okay, bye.
Bye.